name is Don Milady. I'm an emergency physician at Mount Sinai Hospital in Toronto, and I'm a faculty member of the Geriatric ED Collaborative and your host for this afternoon's webinar. We're continuing our series of webinars on core topics in how to create a geriatric emergency department. Today's webinar is on the topic of creating a program for nurse-led geriatric case management in the emergency department. This has many different names: GEM nursing, GEDI nursing, genies, geri nurses, whatever you want to call them. Those of us who focus on geriatric emergency department care, we all agree that case management that focuses on older patients is an essential addition to the workflow, the outcomes, patient and staff satisfaction in the geriatric emergency department. And that the most common model, but as we will see, not the only one, is for nurses to lead that role. We have a diverse audience on the webinar today: clinicians, administrators from emergency departments, healthcare and healthcare systems from across the United States, but also from around the world. Typically, we have 10 or 15 countries represented. We've got 4 excellent panelists to guide us through this topic. Next slide. The Geriatric Emergency Department Collaborative is a network of community and academic emergency departments. We work together to define best practices in geriatric ED care. We educate emergency department clinicians about models of care that improve the care of older people. We support emergency departments and healthcare systems to implement these models of care, and we research and evaluate outcomes. If you share the vision that you see on the screen today, you can join us currently for free. You can check out the gedcollaborative.com, our website, and please follow us on Twitter at the GEDC. Next slide. Our work is generously supported by the John A. Hartford Foundation and the Gary and Mary West Foundation. We really appreciate their support to allow us to do the work that we think is very important. Before I introduce our panelists, I want to ensure that you all know how to use the Zoom webinar platform. All the microphones have been muted, but that doesn't mean that we don't want to hear from you. We do. The best way for all of us to stay in touch is through the chat box. Hover your mouse over the screen, and you'll see the icons usually at the bottom. Click on chat, and please do that now. I'd suggest that you leave the chat box open throughout the presentations, because usually a lot of interesting stuff is happening there. If you're going to make a comment, make sure that all panelists and attendees is selected. There's a little blue box with a down arrow. You can select, it's currently the default position is all panelists. That will only be seen by me. Please select all panelists and attendees. Today's webinar is being recorded. By the middle of tomorrow, it will be on the GEDC website, along with all the slides and the chat box contents. So as we get started, let us, for technical difficulties, you might want to write down these 2 phone numbers. They are our support team at the GEDC Nerve Center, and let them know if you are having problems that you can't solve online. So as we get started, I'd like you to show off your chat box skills. Let us know, type into the chat box where you're calling in from, place and country. You could add if you have a geriatric case management program at your place. I suspect some of you are geriatric emergency nurse case managers. Let us know. Let me know if there's any specific questions you're interested in. So next slide, as you know, this is the topic of our talk. We've got 4 panelists. We're going to provide several different perspectives. Our first presenter will provide an overview, and then we have 3 clinicians. Our first panelist is David Ryan from Toronto. David is a psychologist by training. but for many years was the Director of Education for the Regional Geriatric Program of Toronto. He's my esteemed colleague and mentor. He was responsible for developing one of the first and probably the largest network of geriatric emergency management nurses in North America, if not the world. And he's going to bring that perspective, an overview to his comments about how to get started and how to keep it moving. Our next panelist is Pam Martin, who's one of our Geriatric ED collaborative faculty. She's a family nurse practitioner with geriatric certification. She's a nurse specialist who's the program director of the Geriatric ED in Bon Secours St. Mary's Hospital in Virginia. She directs a program that has a nurse-led geriatric case management program. Lisa Estringer is a nurse who is currently the emergency department case manager at Aurora Sheboygan Memorial Medical Center in Wisconsin. She leads the geriatric emergency department program there. She was a pioneer geriatric case manager for that whole system, even though she remains based in a relatively small rural hospital, and she'll be talking about her experience. And finally, our last presenter will be Colleen McQuown, an emergency physician who's the director of the geriatric emergency medicine program at the Cleveland Veterans Administration. She's a member of the National VA Geriatric Emergency Medicine Advisory Team. So you've got a lot to look forward to. Next slide, please. I'm going to turn it over to David Ryan from Toronto. And David, can you tell us about your 20 years of developing the nurse case manager role involving more than 130 nurses across the province of Ontario?
Thanks very much, Don, and thanks for inviting me to talk with your at your panel this afternoon. That's true for a long time now. I've been working with geriatric and building the geriatric emergency management nursing network, but it was birthed through the regional geriatric programs of Ontario. The regional geriatric programs of Ontario are themselves a network of specialized geriatric service providers, and they provided a foundation for the emergence of the geriatric emergency management nursing service, the nursing network itself. And the role of the geriatric emergency management nursing service is to meet the needs of frail seniors in the emergency department, and also to build senior-friendly skills amongst all staff in the emergency department. Next slide, please, Laura. And it's been a wiggly process of getting from 1995, when a resident, as part of their training, did a review of issues related to frail seniors in the emergency department, and discovered that there were many myths that got in the way of the best care for frail seniors, including things like just basic knowledge of frailty, myths about the fact that older people come at the wrong times to emergency departments and they come for the wrong reasons. Anyway, this gave birth, this happened at Sunnybrook Health Sciences Centre, which is the headquarters of the Regional Geriatric Program of Toronto. And we, together with the hospital itself, piloted a role in 1999, the first geriatric emergency management nurse in Ontario, I think. And it was so successful that soon others in our network wanted to have geriatric emergency management nurses themselves. And gradually in our little network, geriatric emergency management nurses arrived. And then we bumped into your colleagues in the emergency department world. And I say bumped into actually quite literally, because I was walking through the basement of Sunnybrook Health Sciences Centre in Toronto and bumped into Jacques Lee, whom some of you literally bumped into Jacques Lee, and we said hello because we didn't know one another. And he was looking for someone who knew about older people and delirium, and I was looking for someone who was who had interest in falls in mobility in the emergency department, and we've become colleagues ever since. Subsequently, the experience was so successful, starting at Sunnybrook and gradually at our networked hospitals, that the Ministry of Health of Ontario, which is a vast geography, asked us if we would recruit and train and evaluate 8 geriatric emergency management positions in the province. And we went through an interesting exercise. I know that I saw that Marlena Watt is online, and we asked hospitals, emergency departments in the province to tell us why they would like to be the site for an emergency geriatric emergency management nurse. And we discovered that it's astonishing that every hospital and its emergency department thought that they saw more frail seniors in their emergency department than any other emergency department. That was in 2003. We started, we spent a week training those first nurses. And I'll tell you more about those first nurses as we move ahead. These became the original members of the Geriatric Emergency Management Network. And in 2005, we started the first of a series of 2-day conferences. And we've now, I think, were it not for COVID, we would have had the 16th such a conference of the network of geriatric emergency management nurses. We also in 2012 developed a variation on geriatric emergency management nurses, which is an emergency mobile nursing service. And these people were situated in hospitals and went out to long-term care homes when a long-term care home thought that they were going to imminently transfer someone to the emergency department. And emergency mobile nursing services try to take care of those emergencies in the long-term care home and obviating a transfer to the hospital. Subsequently, we met Dawn, and Dawn has become a real champion of geriatric emergency management from the emergency physician side of the house. And gradually the network grew until today. Well, the last time I looked, I retired a few months ago. We had 130 geriatric emergency management nurses in 60 emergency departments. 60, that's getting close to moving into in between a third and a half of the emergency departments in the province in Ontario. And then we have the cadre of emergency mobile nurses as well. Next slide, Laura, please. And in order to develop this, we developed this without having any command and control. It was built on the basis of capital other than command and control. We didn't control any emergency department, not even in our own hospital. And so this systems dynamic became an important guide. And that was that complex systems survive by reducing redundancy on one hand, but preserving requisite diversity on the other. And I hope to show you the ways in which this principle applies itself moving forward. So how did we reduce redundancy? Well, we recruited senior-friendly staff and linked them together. And we developed a frailty-friendly skill set. And we shared roles. We developed a shared role so that every emergency department didn't have to recreate this for themselves. We developed a balanced scorecard approach to the evaluation of the service. All of us tried to avoid placing additional demands on staff in the emergency department as a key element of our working together. And we tried to anticipate, always an ongoing process, emerging needs and priorities, not only within the emergency departments themselves, but also within the health system more generally. And then we wanted to enable diversity because we have our network of 60 emergency departments. They're big emergency department, big hospitals and small hospitals, there are urban hospitals and teaching hospitals and community hospitals and rural hospitals. And so we needed to respect and adapt to the local contexts. And not every hospital not every region of the province of Ontario had the same set of human resources as others did. And so we had to be diverse. We had to enable diversity in recruitment. And I'll show you about that in a little bit. We worked in emergency departments, and a variety of the emergency departments had a variety of resources available to them. And let's see now, in the hospital, there were some that had regional geriatric programs, and some that had geriatricians on staff. I'll just let you look at that slide, which shows you the diversity of the availability of a frailty-friendly staff in emergency departments and in the hospitals of our network. And so we asked, from the point of view of where do GEM nurses come from, because we still don't train geriatric emergency management nurses in academia, although teaching hospitals have become a primary site for the training of, or on-the-ground training of geriatric emergency management nurses. So previously, we had 49% of our 130 GEM nurses were previously an ED nurse. 36% were previously a geriatrics nurse. And 16% had no experience in geriatrics or the emergency department. And this is an important group of people, especially when you're developing services in contexts that have little pre-existing geriatric services available. Because there is, in every emergency department that we've worked with, always someone, often more than one person, who has a special inclination towards senior-friendly care. So even when people have no experience in geriatrics or in the emergency department, we can, with the right kind of training, develop a fully functional and successful geriatric emergency management nurse. Some of our nurses are can we just go back for a second? Some of our nurses are registered nurses, some are clinical nurse specialists, and the new practitioner on the block are nurse practitioners who have an expanded scope of independent practice. Move ahead, Laura. And what do? Well, they screen and refer. They do comprehensive assessments. They do targeted assessments. For when I say comprehensive assessment, it's comprehensive emergency department assessment, keeping in mind that this is not a comprehensive geriatric assessment. A comprehensive geriatric assessment that takes place is undertaken by a specialized geriatric services team and not in an emergency department. But nonetheless, we do a comprehensive systematic assessment. We do targeted assessment, usually for people who have been in the emergency department before and are returned. And we have a record of a geriatric assessment upon which to work. We consult to other emergency department staff, sometimes in formal ways, most often in informal ways. And then there are always more frail people being referred to a geriatric emergency management nurse than can be seen in the time available. They get discharged or they leave before being seen by GEM nurses. And so a small proportion of the people that GEM nurses see are followed up following discharge. And mostly they're looking for the availability of appropriate linkages. Let's move to the next slide.
David, 3 minutes remaining, please.
Okay, so here's a list of the kinds of problems that geriatric emergency management nurses see. They won't be any surprise to you. I'm sure it's the same in all of our emergency departments. Falls and mobility. We really try to emphasize the mobility elements of falls and mobility, delirium, pain, dizziness, and so on. Social admissions, I have to tell you that geriatric emergency management nurses don't like the concept of a social admission for reasons that we may be able to discuss later. Here's a typical workflow. So there's an arrival in the ED, the triage nurse does an acuity assessment, and that's the source of about 10% of referrals. There's a wait time depending upon, for those people, depending upon the triage score. And here is where case finding might happen. Somebody, a geriatric emergency management nurse will come into work in the morning or in the afternoon or in the evening and scan the charts to see to find frail people. These frail people may not have been triaged as being highly acute, but with recognition of the nature of frailty, they, GEM nurses, case find these folks and service them. And then there are, following nursing and medical assessments, there's another 50% of GEM referrals, and then in patient discharge and discharge planning, another 20% of referrals for geriatric emergency management nursing arises. Let's go to the next slide.
David, try to start wrapping up for 2 minutes.
Okay, there are time and resource barriers, access to services outside of the hospital, home and community services for us, and I'm sure for you are problematic. Hospital and human emergency department resources, the ED environment itself, and I know we've had a vigorous literature on the geriatric emergency department. I think this might be the next slide coming up, because as we look ahead, what we want to do, and we know that this afternoon you're going to hear about the optimization of interprofessional frailty-focused services, more than nurses. Adapt network meetings to meet emerging conditions. This is particularly true now in our COVID era. Enhance network communications, support the development of regional networks, standardize mentoring of new GEM nurses, and build the GEM business case. And I think that's the last slide in my presentation, if I'm not mistaken.
Good, thank you very much, David. I'll just let everybody on the line know that if you have questions about how to develop a GEM network and what are the challenges and how to overcome those challenges, I would suggest you're directing your questions to David. So text them into the chat box and he can expand on them during our question and answer period. Thank you very much for that overview. I'm going to turn it over to Pam. Pam, you've developed your own model of GEM nursing at your own home hospital. Can you tell us a little bit about how it works on the ground at your place?
Thanks, Don. Thanks, David. That's a great introduction to what I'm going to be hitting on a couple of the things you said, especially about it being a dynamic process. Here at St. Mary's, our role of geriatric case management has kind of gone through multiple variations. In 2013, when I was hired, it was going to be NP seeing the patients as, so me, and the NP seeing the patients as the primary ED provider. We quickly found out that that was not going to work, and you know, that it was not going to be a sustainable model for us because of you know, Medicare reimbursement and the number of patients that I would be able to see because of the complexity of the older adults. Working with my medical director, we also quickly found out that when you're doing that primary ED physician role, the geriatric principles sometimes get left behind because you're so focused on making sure you are treating and developing your emergency care plan that and covering all your bases as the emergency physician and haven't missed anything in that role, that some of those a lot of the geriatric principles just get left and pushed to the side. So in 2014, we decided that the NP position would go to a consultant role along with our PT, social work, pharmacy role, which we had and all in the beginning as well, and they were already consultant roles. And then my role extended into being the program director as well. We, as the program director, we started trying to transition into primary nurses doing our screenings, and we were going to use the SPICES model, which is sleep disorders, problems eating and feeding, incontinence, confusion, evidence of falls, and skin breakdown. In addition to those, we also had depression screenings, modified caregiver screens, and IADLs and ADLs, because those were also important areas. So nursing came back screaming and yelling that this was way too many screens for them to do, and that the SPICES model was more of an inpatient model than an emergency department model, that most of those were inpatient screens that were already being done once a patient was admitted to the hospital. So we, took their advice and went back to the drawing board, and we wound up eliminating a few of those from, our requested screens. So we took away sleep, incontinence, skin breakdown, because those were all being done if the patient was being admitted to the hospital. I did not take away nutrition, because I felt like, if nutrition plays a huge part in the overall wellness of older adults and their functioning. So I felt like that was an important ED screen, and it was a 2-question screen. So I decided we would keep that one in addition to the cognitive and delirium screens. We, tried transitioning with all of that. It still came back that it was too many screens. So we, went back to the drawing board. We were using the CAM. Nurses said that was too much. I reached out to, EULA and other geriatric emergencies departments to see what they were using as their delirium screen, and they were using the DTS going into the BCAM, so doing the 2-part delirium screen. So I took that one back to my nurses staff and said, okay, what do you think about this one? So then we implemented that one. So we have the mini, and then we just cut down to doing 3 screens a day. 3 screens, the delirium screen, the mini cog for a dementia screen or cognitive screen. And then we use the 10-meter walk instead of the tug for our functional screen, because it was easier than moving chairs out of the rooms and so forth, because we didn't have enough room to do the 10-meter walk. So, we tried implementing that for, a year or two with, nursing shortages and all the different things that have come about with COVID. Now we are back to just getting them to do 1 screen. We're focusing and re-educating on, let's just get the delirium screen. We've always had the TRIST as our initial intake screen, so the triage risk screening tool. We've always had that as their, and nursing compliance was that, and triage has been, 75 to 90% at any given time. So that one's always been consistent. And now we're working primarily on getting them to do the delirium screen. So we've kind of gone around multiple iterations of, what screens we want, who's going to do them, and how that's going to be effective. And I think that's a key point in starting any program, is it's going to be a dynamic program. You're going to have to, try something, go back, reevaluate, and try something else. Next slide, please. And this just talks about how we identify our patients. So I said we use the ESI level, or I didn't say that, but that's what we do. We focused our patient population on TRIST 2 and 3 and acuity level 3, because in our data, it showed that as the TRIS got higher for the acuity 3s, those patients were more likely to be admitted to the hospital. And we want to primarily see patients that are going to be discharged home so that they can get the appropriate resources as they're going home. We also have our hospital has an accountable care organization. We are one. And so we do try to see those patients, and that's identified by the yellow stars on that. And then the third way we get patients would be potential 30-day readmits, and that the icon under that question mark is our 30-day readmit symbol. So that shows up on our track board anytime a patient comes into the ER. That's a potential 30-day readmit. So that alerts all members of the team, you know, to kind of take a look at that and see if there's anything we can offer from an ER perspective to help discharge that patient back into the community to prevent that 30-day readmission. Next slide, please. So now David talked about, you know, several reasons.
I'll just tell you, you got 2 minutes left.
Okay, several reasons patients come into the emergency department and that we see. So I'm going to give a quick case study. The first, it's a 70-year-old.
What happened to Pam? I'm not hearing her.
She's muted. I will unmute her. There we go.
Keep 2 in the last.
Pam, you were briefly muted, so maybe just start from the beginning of the case example.
Okay, it's a 78-year-old female. She comes in from home with frequent falls, 2 in the last 24 hours. She was seen at another hospital a week ago for the same. Patient is unable to care for herself at home, according to a neighbor that's in the ER with her. She had a PT consult in the ER, a case manager, social worker consult in the ER. Her medical workup was unremarkable. Her insurance was Anthem, and it had the Care More component to that, which is, so we knew from that piece that they had contracts at local facilities. And so we were able to contact them and have the patient transition directly from the ER into a skilled nursing facility to get the care she needed without having inpatient hospitalization. Thanks.
Good. I know, Pam, that you have, you've got another minute left if you want to do another case example.
Okay, so we have an 83-year-old patient who comes into the ER with hepatic encephalopathy. She had just been discharged from the hospital 5 days ago. I actually saw her on in the ER on her first admission, and then saw her, you know, as she was coming through the ER this second time. So I went in to speak with her, and her significant other said her medicines don't seem to work as well when she gets home. So I met with the pharmacist, and we started saying, you know, did they switch her to a generic? Did they change the dosage once she was discharged? Kind of trying to figure out what was the difference between the home environment and the hospitalization. And you know, so there was no change in the medications. It was not a generic med. The dosage had not been changed. So I go back in and talk to the patient and ask, how are you measuring your medicine? You know, how are you taking your medicine? And she was using a teaspoon instead of tablespoon. And so we were able to, you know, do some education regarding that. And she didn't have to come into the hospital at that point either. So.
Thank you very much, Pam, for ending on that very positive note. One more life saved by a GEM nurse. Well done. Let's go on to Lisa, Lisa, Pam works in a fairly large urban hospital. You work in quite a different setting. Can you please tell us about your setting and how GEM works, or geriatric case management works at your place?
Absolutely. So as you said, I work at a much smaller site than the previous discussion. So puts a different perspective on it. I have been a nurse for about 20 years. 9 of those were a staff nurse in the emergency department. And then the last 6 years, I've been spending it as the ED case manager. So today I'll kind of be talking about my role and the implementation of the case management role and the implementation of the geriatric emergency department program that we have in place here at Sheboygan Memorial. Next slide. So at Sheboygan Memorial, we have 185 licensed beds. We are currently a level 3 geriatric emergency department accredited by the American College of Emergency Physicians. In 2019, we saw just over 23,000 patients through the emergency department. 25% of those were 65 or older. And of those 65 and older, 61% of those discharged home. So that kind of gives you a perspective of our size and what we're managing in our emergency department. And we only have currently 12 emergency department beds. Next slide. So when they went to actually initiate getting a emergency department case manager, they really wanted to make sure that that person was dedicated to the emergency department. They did not want that person going from the inpatient world to the emergency department and vice versa. And really what drove them to get that position created was because leadership was finding our hospitals having some complaints from not only patients, but the patient families, that we were really not helping support them beyond the emergency department walls, and maybe not managing them quite as the best we could in the ER, especially those that were 65 and older. So then they started the case management position about 6 years ago, like I said, when I got hired. And the best part of that was when I got that role, I was able to really make it what I wanted to. They really gave me the freedom to develop it and create it and kind of implement a lot of the workflows and how I do my job. And what I find typically, like you and most people in the emergency department, there is no typical day. So there's really no workflow that works for every day. Each patient and each situation is going to be different, as most of you know who work in the ER. But with that being said, oftentimes they get phone calls from providers or nurses when they see a need from a particular patient, when they're either in there with their initial assessments or they have screened the patient in triage with the ISAR screening tool. We use the ISAR, which is identifying seniors at risk. So anything 2 or greater is considered a higher risk patient. Most often I'm getting involved with the 3s or higher. I also watch the track board, which lists all our patients, which has the ISAR screening tool on it, which would provide me a number so I know how each 65 and older patient is scoring on that screening tool. I also do follow-up calls with the higher risk individuals once they leave the emergency department within 3 to 5 days as well. And then I also watch the track board for our 30-day return. So any patient that has been in the hospital and is returning back to us is also one of my individuals that I will reach out to, make sure we haven't missed anything during their stay. Maybe there's something that we could be providing them in addition to what we did when they left the hospital, to see if we can better support them. I also lead the geriatric program here. So with that, I created a geriatric program committee. That committee involves a multidisciplinary team, which has my management team, also has RNs from the emergency department, techs from the emergency department, physical therapy representation, home health representation, palliative care, pharmacy. So it's kind of a great team to put together to kind of brainstorm, come up with good procedures to better support our older adults in the emergency department, workflows that works for everyone involved, and then to better implement them, be able to receive feedback, and then improve on all the workflows and processes on a monthly basis. So we meet every month and provide feedback to one another, and then be able to grow and improve on everything. I also collect all the data, do all the data reporting and feedback as well to leadership. In the beginning, I was doing all manual data, and thankfully I have support from our Aurora Senior Services team, which has developed great reporting systems that has helped me greatly and immensely to be able to provide feedback to the staff. And I know it's very difficult for staff these days. RNs are always getting more work, never anything removed from their plate. So, it's always hard to buy in nurses to do a little bit more. And when we implement another procedure or another workflow to help better care for our older adults, I think the best part is to be able to provide those feedback pieces and to show that the work is actually making a difference. And once you can show a nurse that they are making a difference by doing the processes and the workflows, they're better. It's easier to get them to buy into it and easier to get them to do the work. That little extra time becomes not such a big deal. So that has been greatly beneficial to us. The other part of my role as case manager here was building community partnerships. And when I first got hired here, I spent about 1 month just going out into the community, meeting with all the different partners that I would be working with, Department of Health, Aging and Disability Resource Center. I met with each and every assisted living, skilled nursing facility, home care agencies, to really build those partnerships and relationships, which has helped me in the long run. And we work together back and forth. If they need something, they can reach out to me. I reach out to them. I also sit on 3 community committees or county committees here in Sheboygan County, where we reside. And one of them was a big part of initiating. It was called the Dementia Crisis Task Force. And we found that we had a problem in our community, and we came together as partners, and we actually developed a huge training program for those who have dementia with behavioral disturbance, because we weren't managing those patients well in our community. So we came together, we had the problem, and we fixed it by creating better training for those that are dealing with those individuals. So we've trained law enforcement, EMS, all the skilled nursing facilities, assisted living facilities in our area. So it's been a great ability to be a part of our community as well in this case management role. And we've now actually trained over 2,000 people in that, and which has been great success. And we are actually in the process of creating videos so we can share it with other communities. So getting into next slide, sorry.
Lisa, 2 minutes left.
Okay, all right. Our geriatric program has been phenomenal and very successful. We have many parts to it. It's always moving and evolving. Some of the bigger parts are we use that our ISAR screening tool of identifying seniors at risk tool upon triage, which provides us an idea of how high risk they are or frail they are as an older adult. We use a referral process, which all the nurses have been educated on, those 4 referrals, and then how to refer them on. And so they know the exact workflow from the very beginning to the end, so that they can provide those resources even when I'm not there, because of course we only have me and I'm not there 24/7. We have a fall protocol, which anybody 65 or older that comes in as a result of a fall goes through a process where we check orthostatic vitals. We do a tug test, a timed up and go test. We meet with our physical therapists. They may do a consult in the ER, and then we provide an outpatient resource, whether it be outpatient PT or a home health physical therapy order, or maybe even transition them to a skilled nursing facility straight from our emergency department to a skilled facility. We work as a team, so we always we tend to have huddles with all the disciplines involved in somebody's case. If we have a high-risk individual, we'll sit down and we talk as a physician, a case manager, physical therapist, or someone out of another discipline to really come up with that best plan of care for each individual before they discharge home. And we also then always, again, go back to the outcomes and how can we be improving on what we're already doing. Next slide.
Lisa, maybe we'll just text that content into the chat box
Okay.
so that we can move on. Thanks,
Okay.
really, thanks a lot. That was really a great view of the super wonder gem nurse of Sheboygan, Wisconsin. Thanks a lot.
Yeah.
And then moving on to quite a different setting, Colleen McQuown, you work at a level 1 geriatric ED accredited place in a large city with the Veterans Administration, but the VA has like really chosen to take a different route to case management. Can you tell us about that?
Yes, thank you, Don. So I also want to acknowledge Dr. Jill Hudad here. She was the developer and the creator of the program here in Cleveland. Move on. So this is one of our patients, very typical emergency department patient coming in with essentially driven by overwhelming caregiver burden. And Mr. C had been a reverend who actually had done the invocation for Barack Obama when he visited Cleveland in 2008, and essentially due to dementia, was creating having a lot of difficulty having his wife take care of him at home. Go ahead, next slide. And so rather than just admitting him to the emergency department, we had our team jump in and care for him. And our team consists of ICTs, which I'll tell you about in a minute, nurses, physicians, physical therapists, pharmacists, and administration. Go ahead. So ICTs. So rather than developing a nurse-led program at our Cleveland VA Medical Center, we decided to use ICTs. So ICTs are former military medics and corpsmen that had been in the service. So they are veterans themselves and incorporated through a pilot program in 2012 as force multipliers in the emergency department. Go ahead, next slide. So ICTs have this awesome wealth of information. They can save your life if you are shot on the front lines in a combat zone. However, how does that translate to being able to take care of geriatric patients in the emergency department? So Dr. Hudad and many others created an extensive training program in the emergency department that involved didactics, case-based simulations, we actually use practice patients and develop competencies, and anyone that's in the VA system can access our share drive with all of these resources on it, all of our didactics and videos that we created for each geriatric screen that we had ICTs do. Go ahead, next slide. So how our program works. We use the identification of seniors at risk tool that is done by the triage nurse. We also have a program, so how we do it is if an ISAR of 3 or more, we put it in as a geriatric emergency department consult for the ICTs to see the patient. And that way, it's an easy way for us to track our flow. And also because we've had extensive education to all of our ED staff, and also they've seen 4 to 5 years of the success of our program. Any staff member that thinks there may be a geriatric syndrome or feels that the veteran has unmet needs can place the consult as well. So about 25% of our consults come from staff members identifying them, and then the rest come from the identification of seniors at risk. So once they're identified and that consult is placed, the ICT then does the geriatric screens in the emergency department, comes up with a plan involving the ED social worker and the AED provider. And then we also do follow-up phone calls, sometimes multiple times over the next 2 to 4 weeks. All right, next slide. Thanks. This is an example of our geriatric screening form, and all of this is one side of the form. We have a double-sided form, but all of the screens that our ICT does. Next slide. And then we have this playbook. We developed this playbook. So these ICTs are not licensed providers. We've developed competencies for all of these slides or all of these screens. However, we wanted them to be able to be empowered to be able to talk to the providers and help them come up with a game plan for each of the geriatric syndromes that they've screened for. So we came up with a playbook for each one of our geriatric screens. Next slide. And then we came up with order sets for each one of our geriatric screens as well to help coordinate and help plan the ED course. Next slide. And then typical outcomes in the emergency department, we provide equipment like talking pill boxes, we get physical therapy involved, we refer for capacity evaluation, we expedite long-term care placement, we expedite respite care, we expedite referrals to home health, home modifications, and also send our patients home with things like hearing amplifiers and rollators. Next slide. And then this is one of the, I think, one of the things that's very successful about our program is because we follow up on patients and make sure that all the things that we've recommended are getting done. And so this is our task tracker. So you can see there's things like call patient's daughter Diamond and make sure that the patient is going to attend all of his follow-up visits. Or is this, has this consult been initiated yet? What else do we need to do? We find a lot of times it's the veterans have flip phones and don't know how to get to their voicemails. And we need to get a whole team involved to make sure that they're getting all the care that they need. Next slide. And so following up with this patient. So Christina, one of our first ICTs that worked in our emergency department and did this program at the very beginning. She went and talked to this veteran, introduced herself as another veteran, got that veteran to veteran connection, and then came back with a care plan for his falls, his polypharmacy, for his dementia, and got him within a few days of his ED visit, he was able to go home. The social worker from his office contacted the family, got him set up with all of the resources they needed to help them out at home. Go ahead, next slide. And he ended up needing some of the VA resources right away because his wife actually had a heart attack. And we were able to immediately get him into respite care and have him taken care of while she could get back and take care of her own needs. And so we really treated both the patient and the whole family and came up with a care plan that was initiated in the ED that allowed him to stay out of long-term institutionalization and be able to be cared in the emergency department. Next slide. All right, so wild house here. So this is just some pictures of all the different veterans that we have served. The ones in the bottom left corner are two that are on our patient advisory panel for developing our geriatric emergency department. And they both got rollators from our emergency department to help them stay. All right, and I think that is the last slide.
Good, thanks Colleen for the entertainment from the background, but also for the really, as I put in the chat box myself, like I think most people would not imagine that somebody from such an external perspective and with such a different set of skills would be able to do this role. And I think it's really, you know, daring and innovative that the VA, you guys in particular, you know, really extended the role in that way. It's an amazing program. So we do have 6 minutes left for questions and answers. I'm going to ask Eula to lead that off. Eula, do you want to take over?
Sure. So again, want to just thank the speakers and also the participants. We had over 100+ people on today's webinar, participating from all around the world. A lot of representation from the US and Canada, but also individuals from Europe. So we had Ireland, we had Switzerland, we had the Caribbean islands, Trinidad, Tobago, and even around the world and from Australia. So again, this the work and the examples that you hear today, this is not just relevant to your EDs and your hospitals, but around the country and around the world. I wanted to give a shout out specifically to Hackensack. There were a lot of people from Hackensack Hospital in New Jersey. So great showing. So question for the group. And want to also just make sure everyone has been paying attention to the chat. There have been a lot of interesting comments and summaries and highlighted points and summary themes. But one thing that I wanted to bring and ask each of the participants, if you had one quick tip to give to those listeners or participants on the call today, if you were to start a program, what would that one quick tip be? Because many might be going like, wow, we're never going to be able to do what you guys have. That's overwhelming. But I think you all had examples of how you really tried different things and you didn't start off humongous, you started off small. But if you had one quick tip, what would that tip be? I'm just going to go from top to bottom. Start with
Don't mind giving a tip?
Yes.
So one of the tips I was thinking about as I was listening to everyone was the importance of, when you were developing a new service,
is the importance of engaging both formally influential people and informally influential people. Within every emergency department, as in within every working team, there is someone to whom other people turn for advice. And usually when something new comes along, staff will go to that person and ask them, what do you think about this geriatric emergency management situation? And if sometimes that influential person is a formally influential chief of staff, and sometimes it's somebody informal. And often those informal influentials aren't recognized by others. But if those influentials say, oh, well, I don't know, it's going to be more work for us. It's going to be harder to get your innovation off the ground.
Thank you. So I'm going to just go down the line. So Lisa.
Yep, I would say including all of your disciplines that it's touching. I mean, everybody needs to be involved. Everybody needs to be providing their input, and also start small. Like everybody's been saying, it's not going to happen right away. Not everything is going to be perfect. You're going to find that things don't work at times, and you're going to have to step back, reevaluate, and try something different. So just kind of trial and error, and just one step at a time.
Could I add to Ula's comment by saying that, in the initial evaluation, it's important not to be too heroic. Like it's the outcomes that we're looking for may not be saving the emergency department money in the first year, but it might be having the chief of staff or the staff in the emergency department feel as if having a gym nurse there adds value.
Wonderful. Thank you. Pam.
Know the reason why you're doing this. So what's the purpose of your Jerry ED? Is it to save money? Is it to reduce emissions? What is the purpose? Is your focus going to be admitted patients or discharged patients? So, and you can get this information by asking your administrators what keeps them up at night. What keeps them up at night to get their buy-in and see how your program can fit into what keeps them up at night so that you can get the resources you need.
Wonderful. Thank you. And finally, Colleen.
Yeah, I would say one of the things that makes our program very successful is incorporating the caregiver into the plan. So interviewing the caregiver in the emergency department, making sure that we have their phone number so that when we do our follow-up phone calls that we can include the caregiver, and making sure that everything that we think needs to be done gets done. And I see quick, and there's a question in the comments about how the ICT Planet program has been replenished. It's no longer a pilot program. It's a fully implemented program.
Good. Eula, any other last comment? Actually, we've got, yes, Laura, can you move to the next slide, please? Just a reminder of our contact points. Next slide, please. I just want to draw everybody's attention who's on the line. The Acute Care of the Elders National Conference, which is run by Advocate Aurora every year, and which is really, many of us have attended live, is really worth the trip to Milwaukee. But this year you don't have to go to Milwaukee, you can get it right here, and you can get it for free. I'd encourage you to register for it. It's an excellent, will be an excellent 3 hours of your time. Next slide, please. Would like to thank one more time our supporters, the John A. Hartford Foundation and West Health, for their generous contribution to the Geriatric ED Collaborative. And as we're wrapping up, I remind you that we will be back here on December 9th for our next webinar, which will be on how to implement a volunteer program specifically for older ED patients in the emergency department. So volunteers, specially trained volunteers, and we'll be doing a session on that on December 9th. So I'd like to extend a really big thank you to our 4 panelists for contributing their scores of years of experience and knowledge and wisdom. I think it will give a lot of people a lot of ideas, and I hope that it will move forward the implementation of geriatric emerge case management. Thanks to everyone, and we'll see you again in a few weeks.